structure of the teeth. A tooth has a crown, neck, and root. Each type of tooth has a characteristic appearance. The crown projects from the gingiva. The neck is the part of the tooth between the crown and root. The root is fixed in the alveolus by the fibrous periodontal membrane. The number of roots varies. Most of the tooth is composed of density, which is covered by enamel over the crown and cement. Over the root. The full cavity, which is the tooth cavity, contains connective tissue, blood vessels, and nerves. The root canal transmits the nerve and vessels to and from the full cavity throughout the apical, which is the root foramen. The tooth sockets occurs within the alveolar process of the maxilla and mandible and are the skeletal features that display the greatest change during a lifetime. Adjacent sockets or alveoli are separated by interalveolar septa. Within the sockets, the roots of teeth within more than one root are separated by intraradicular septa. The bone of the socket has a thin cortex separated from the adjacent labial and lingual cortices by a variable amount of trabeculated bone. The lateral wall of the socket is particularly thin over the incisor teeth. The reverse is true for the molars, where the lingual wall is thinner. The lateral surface commonly is broken to extract incisors, and the lingual surface is broken to extract molars. The lingual nerve is closely related to the medial axis of the third molar, therefore take caution to avoid injuring this nerve during their extraction. The periodontium includes the cement and the periodontal membrane. The roots of the teeth are connected to the bone of the socket by a springy suspension forming a special type of fabric termed as composite. The collagenous fibers extend between the cement of the root and the periosteum of the alveolar wall is the periodontal ligament or membrane. It is abundantly supplied with saxiopresoreceptive nerve endings, lymph capillaries, and glomerular blood vessels that act as hydraulic cushioning to curb axial masticatory pressure. Presoreceptive nerve endings are capable of receiving changes in pressure as stimuli. Vasculature of the teeth, the superior and inferior alveolar arteries, branches of the maxillary arteries, supply both the maxillary and vestibular teeth respectively. Veins with the same length and distribution accompany the arteries. Lymphatic vessels from the teeth and gingival vasa mainly to the submandibular lymph nodes. The innervation of the teeth, the superior and inferior alveolar nerves, branches of CN5 and CN5 respectively arises from the dental plexuses to supply the maxillary and mandibular teeth. The palate forms the arched roof of the mouth and the floor of the nasal cavity. It separates the oral cavity from the nasal cavity and the nasopharynx, the part of the pharynx lying superior to the soft palate. The superior nasal surface of the palate is covered with respiratory mucosa and the inferior oral surface is covered with the oral mucosa. The palate consists of two regions, the hard palate anteriorly and the soft palate posteriorly. The hard palate is vaulted, which is concave. This space is filled by the tongue. When it is at rest, the anterior two-thirds of the palate as a bony skeleton formed by the palatine process of the maxillary, and the horizontal palate of the palatine bone. Three foramina are open on the oral aspect of the hard palate, the incisive fossa and the greater and lesser palatine foramina. The incisive force of the maxilla is a slight depression posterior to the central teeth. The nasopalatine nerve passed from the nose throughout a variable number of incisive canals and foramina that open into an incisive fossa medial to the third molar tooth. The greater palatine foramen pierces the lateral border of the bony palate. The greater palatine vessels emerge from this foramen and runs anteriorly on the palate. The lesser palatine foramina posterior to the greater palatine foramen pierces the foramina dorsal palatine bone. The lesser palatine foramina transmits the lesser palatine nerves and vessels to the soft palate and adjacent structures. The soft palate is the more posterior third of the palate, which is suspended from the posterior border of the hard palate. The soft palate has no bony skeleton, however, it is included in anterior membranous aponeurosis palate that attaches to the posterior edge of the hard palate and a posterior fibromuscular palate. The soft palate extends posterior or inferiorly as a curved rib margin from which hangs across the uvula. The soft palate is strengthened by the palatine aponeurosis, which is the aponeurosis palate formed by the expanded tendon of the tendon raised palatine. The aponeurosis attached to the posterior margin of the hard palate is fixed anteriorly and then posteriorly. When a person swallows the soft palate, initially it tends to allow the tongue to press against it, squeezing the bolus of food to the back of the mouth. The soft palate then is elevated posteriorly and superiorly against the wall of the spine, thereby preventing passage of food into a nasal cavity. Laterally, the soft palate is continuous with the wall of the spine and is joined to the tongue and fine by the palatoglossal and palatopharyngeal arch, respectively. The faucet is the passage from the mouth to the spine, including the lumen and its boundary. The faucet is bounded superiorly by the soft palate, inferiorly by the root base of the tongue, and laterally by the pillars of the tongue. The palatoglossal and palatopharyngeal arch. The isthmus of the faucet is a circumscripted space that establishes the connection between the oral cavity proper and the oropharynx. The isthmus is bounded anteriorly by the palatoglossal folds and posteriorly by the palatopharyngeal folds. The palatine tonsils, often referred to as the tonsils, are masses of lymphoid tissue, one on each side of the oropharynx. Each tonsil is in a tonsillar fossa, tonsillar bed, bounded by a palatoglossal and palatopharyngeal arch and the tongue. The superficial features of the palate, the mucus of the hard palate is tightly bound to the underlying bone. Consequently, through mucus injections, they are extremely painful. The lingual gingiva, the part of the gingiva covering the lingual surface of the teeth, and the alveolar process is continuous with the mucus of the palate. Therefore, injections of the anesthetic agent into the gingiva of a tooth and after by the adjacent palatal mucosa teeth to the mucosa are mucus-secreting palatine glands. The orifices of the ducts of these glands give the palatine mucus appearance or orange peel appearance. In the midline posterior to the maxillary incision teeth is the incision papilla. This elevation of the mucosa lies directly anterior to the underlying incisive fossa of the bony palate into which the incisive canals open. The incisive foramina are the openings of the incisive canal that transmit the nasal palatine nerve and vessels. The incisive papilla is the injection site for anesthetizing the nasal palatine nerve. Varying laterally from the incisive papilla are several parallel transverse palatine folds or palatine ridges. These folds are gained with manipulation of food during mastication, passing posteriorly in the middle of the palate. From the incisive papilla is a narrow pale-ish, whitish state. The palatine teeth. They might present as a ridge anteriorly and the groove posteriorly. The palatine raceme marks the site of fusion of the embryonic palatal processes as shown. Muscles of the soft palate. The fine muscles of the soft palate arises from the base of the cranium and descends to the palate. The soft palate might be elevated to that it is in contact with the posterior wall of the spine. The soft palate might also be drawn inferiorly so that it is in contact with the posterior part of the tongue. Sensing the soft palate pulls its side at an immediate level for attachment, nerve supply, and action of the muscle of the soft palate refers we are going to continue right with all these muscles of the soft palate and which are listed below, which are the levator belli palatini or levator muscle, or the soft palate is a cylindrical muscle that runs inferiorly, spreading out in the soft palate where it attaches to the superior surface of the palatine aponeurosis. The tensor belli palatini or tensor muscle of the soft palate is the muscle with a triangular belly that passes inferiorly. The sternum form and its apex hooks around the pterygoid hamulus. The hamulus of the medial pterygoid blade before spreading out as the palatine aponeurosis. The palatoglossus is a slender slit of muscle that is covered with mucous membrane. It forms the palatoglossal arch. The palatopharyngeus is a thin flat muscle also covered with mucous membrane, forming the palatopharyngeal arch. The musculus uvulae, the uvular muscle, inserts into the mucosa of the uvula. The vascular innervation of the palate. The palate has a rich blood supply, chiefly from the greater palatine artery on each side. A branch of the descending palatine artery, the greater palatine artery, passes throughout the greater palatine foramen and runs anteromedially. The lesser palatine artery, a small branch of the descending palatine artery, enters the palate throughout the lesser palatine foramen and anastomosis with the ascending palatine artery, a branch of the facial artery. The veins of the palate are tributaries of the pterygoid. Then plexus. Take a look at your atlas. The dissection of the posterior part of the lateral wall of the nasal cavity and the palate. The sensory nerves of the palate are branches of the pterygopalatine ganglion. The greater palatine nerve supplies the gingival, mucous membrane, and glands of most of the hard palate. The nasopalatine nerve supplies the mucous membrane of the anterior part of the hard palate. The lesser palatine nerve supplies the soft palate. The palatine nerves accompany the artery throughout the greater and lesser palatine femina, respectively, except for the tensor belli palatini supplied by CN5 or muscles of the soft palate are supplied throughout the pharyngeal plexus of nerve. The tongue is a mobile muscular organ that can assume a variety of shapes and positions. The tongue is partly in the oral cavity and partly in the pharynx. At rest, it occupies essentially all the oral cavity proper. The tongue is involved with mastication, taste, deglution, articulation, and oral strengthening. Two or these, however, are its main functions. The one forming words when speaking, and the other putting food into the spine when swallowed. Parts and surfaces of the tongue. The tongue has a root, a body, and apex, a curved dorsal surface or dorsum, and an inferior surface. Some authors describe the root of the tongue as the inferior, relatively fixed part attached to the hyoid bone and mandible, and in proximity to the geniohyoid and mylohyoid muscles in between. Most commonly, the root is defined as the posterior which is also known as sulcal third of the tongue. The body of the tongue is the remaining part of the tongue. Hence, its definition varies with the definition of the root. Most commonly, the body is defined as the anterior two-thirds of the tongue. The apex of the tongue is usually the pointed anterior part of the body. The body and the apex of the tongue are extremely mobile. The dorsum of the tongue is the posterior superior surface of the tongue, which includes a V-shaped root, the terminal sulcus, the apex of which points posteriorly to the foramen septum. A small pit that is the non-functional remnant of the proximal part of the anterior thyroglossus duct from which the thyroid gland develops. The terminal sulcus divides the dorsum of the tongue into the anterior part, presulcal or oral part, which lies in the oral cavity proper, and the posterior part, postsulcal or pharyngeal part, which lies in the oropharynx. The anterior and posterior part both include rough, irregular surface. The mucous membrane on the anterior part of the tongue is rough because of the presence of numerous small lingual papillae. The valence papillae are large and flat topped. They lie directly anterior to the terminal sulcus and are surrounded by deep mud-like trenches, the walls of which are studded by taste buds. The ducts of serous glands open into these trenches. Foliae papillae are small lateral folds of the lingual mucosa. They are fully developed in humans. Piliform papillae are long and numerous and contain afferent nerve endings that are sensitive to touch. These scaly wreath-like papillae are pinkish gray and are arranged in V-shaped rows that are parallel to the terminal sulcus except at the apex of the tongue, where they extend to be arranged transversely. Punctiform papillae are mushroom-shaped and appear sphinctered because they are scattered among them. Filiform papillae are most numerous at the apex sides of the tongue. The valve foliate and most of the punctiform papillae contain taste receptors in the taste buds. A few taste buds are also in the epithelium covering the oral surface of the soft palate, the posterior wall of the oropharynx, and the epiglottis. Incidentally, filiform papillae that make the tongue of some animals so raspy. The mucous membrane of the dorsum is thin over the anterior part of the tongue and is closely attached to the underlying muscles. At depression of the dorsal surface, the midline groove, which is the medial sulcus, divides the tongue into right and left sides. It also indicates the site of fusion of the embryonic distal tongue bud. Deep to the midline groove is the fibrous lingual septum that divides the tongue into right and left halves. The posterior part of the tongue is the part located posterior to the terminal sulcus on the body. Latoglossal arcs, which are structures that demarcate the posterior boundary of the oral cavity. Its mucous membrane is thick and freely movable. It has no lingual papillae, but the underlying nodules of lingual lymphatic follicles give this part of the tongue its irregular cobblestone appearance. The nodular masses of lingual follicles are collectively known as the lingual tongue spires. The inferior surface of the tongue, sublingual surface, is covered with a thin transparent mucous membrane throughout which one can see the underlying veins. With the tongue raised, observe the lingual frenulum, a large midline fold of mucosa that passes from the gingiva covering the lingual aspect of the anterior alveolar ridge to the posterior inferior surface of the tongue. The frenulum connects the tongue to the floor of the mouth while allowing the anterior part of the tongue to move freely. On each side of this mucosa folds, a deep lingual vein is visible throughout the thin mucous membrane. Also observe the lingual scarring tube. papilla on each side of the basic lingual frenulum, that is location of the opening of the mandibular duct from the sublingual salivary gland. Muscles of the tongue. The tongue is essentially a nasomos that is mostly covered by mucous membrane, although it is traditional to use of providing a description of the actions of tongue muscles, ascribing a single action to a specific muscle or implying that a particular movement is the consequence of a single muscle action. Really oversimplify the actions of the tongue and are misleading. The muscles of the tongue do not act in isolation, and some muscles perform multiple actions with part of one muscle capable of acting independently, producing different even antagonistic actions in general. However, extrinsic muscles alter the position of the tongue, and intrinsic muscles alter the shape. The four intrinsic and four extrinsic muscles in each hand of the tongue are separated by the fibrous lingual septum that merges posteriorly with the aponeurosis of the tongue. Right. The four attachments, nerve supply, and actions of the intrinsic and extrinsic muscles of the tongue. Right. We are mentioning the extrinsic muscles of the tongue. The extrinsic muscles are the genioglossus, the hyoglossus, the styloglossus, and palatoglossus. Originate outside the tongue and attached to it. They mainly move the tongue, but they can alter its shape as well. The genioglossus advanced shape most contributes most of the bulk of the tongue. It arises by a sore tendon from the superior part of the mental spine of the mandible. It fans out as it enters the tongue inferiorly, and its fibers attach to the entire dorsum of the tongue. Its most inferior fibers insert into the body of the higher bone and pull the roof of the tongue anteriorly, which might be done as an element of the complex action of protruding the tongue. Acting bilaterally, the genioglossus muscle depresses, especially the central part of the tongue, creating a central furrow of roof. Acting unilaterally, the genioglossus will deviate the tongue towards the contralateral side when the tongue has been protruded. Contraction of the anterior part of the muscle returns to apex. The hyoglossus, a thin quadrilateral muscle, arises from the body and radial horn of the hyoid bone and passes superior anteriorly to insert to the side inferior aspect of the tongue. The hyoglossus depresses the tongue, especially pulling its sides inferiorly. It also aids in retraction of the tongue. The styloglossus, a small short muscle, arises from the anterior border of the styloid process near its tip and the styloid ligament. It passes infero-anteriorly to insert into the side and inferior aspect of the tongue. Its fibers interdigitate. With those of the hyoglossus muscle, the styloglossus retrudes the tongue and curves its side, acting with the genioglossus to create a throat during swallowing. The palatoglossus originates in the palatal aponeurosis of the soft palate and inserts into the side of the tongue. It enters the lateral part of the tongue with the styloglossus or passes almost transversely throughout the tongue with the intrinsic transverse muscle fibers. The palatoglossus is in its innervation and function actually more palatal than glossal. That is, it is more a part of the soft palate than of the tongue, although it is capable of elevating the posterior part of the tongue. It might pull down the soft palate. Most commonly, the palatoglossus muscle acts laterally approximately the palatoglossal force to constrictismus of the process. The palatoglossus enters the lateral part of the tongue. with the styloglossus, which passes almost transversely throughout the tongue, influencing transverse muscle fibers. Intrinsic muscles of the tongue. The superior and inferior longitudinal transverse and vertical muscles are confined to the tongue. They have their attachment entirely within the tongue and are not attached to bone. The superior longitudinal muscle of the tongue forms 18 layers due to the muscle membrane on the dorsum of the tongue. Running from its apex to its roots, it arises from the multicellular layers and the lingual septum and inserts mainly into the mucous membrane. The superior longitudinal muscle covers the apex of the tongue, pushing it against the palate or turning the protruded apex upward towards the nose, making the dorsum of the tongue concave longitudinally. The inferior longitudinal muscle of the tongue consists of a narrow band close to the inferior surface of the tongue. It extends from the apex to the root of the tongue. Some of the fibers attached to the hyoid bone. The inferior longitudinal muscle curves the apex of the tongue clearly, making the dorsum of the tongue convex. The superior and inferior longitudinal muscles are together to make the tongue short and in retracting the protruded tongue. The transverse muscles of the tongue lie due to the superior longitudinal muscle. They arise from the lingual septum and run lateral to its right and left margins, which fibers insert into the submucous fibrous tissue. The transverse muscles narrow and increase the height of the tongue. The vertical muscle of the tongue runs inferolaterally from the dorsum of the tongue. It flattens and broadens the tongue. Acting with the transverse muscles, they make the tongue long and narrow, which might push the tongue against the front teeth or protrude the tongue from the open mouth, especially when acting with the posterior inferior part of the genioglossus. Let us take a break right here, and we'll be back in a short period. Take a break. 1, 2, 3.